All right, I'm Sonia Reed, and I'm from the Bellevue School District, and I am going to be introducing our next speaker, Dr. Nicholas Weiss, and he's going to be talking on the very timely and important topic of teen substance abuse. Dr. Weiss attended Harvard Medical School, continued his post-grad training at the University of California. He has worked in senior child, adolescent, and family psychiatry since 2008, but he looks like a child. He is currently a staff member at Seattle Children's and the Seneca Center. He remains an associate professor at the University of Washington. He is a published journal and book contributing author on varied topics across the mental health spectrum, including ADHD, autism, psychotic spectrum, depression, along with various medication interventions and their outcomes. He's also a member of the American Society of Addiction Medicine. I just found that interesting. Please help me welcome Dr. Weiss.
Sure.
We have a remote audience as well, and so
Okay.
if anyone asks questions during the talk, if you could repeat the question.
Absolutely. And this advances things. Okay,
Yeah, there you go.
great. Can everybody hear me okay? Great. Well, welcome. Thank you for coming. I'm really happy to get to talk about this topic. I think partly because it's so important, but also I think there are a lot of, misunderstandings about what's going on in the world of substance abuse and substance use disorders in teens. And I'll frame my talk by saying that while I'm going to be talking about specific evidence-based interventions, as with so much that we do, the bigger context, without question, is our relationships with the youth. And I think it's no more important than in the area of substance use, where building relationships of trust that allow you to help youth to feel comfortable disclosing, and then help youth feel comfortable accepting guidance and advice, and then coming back again after they have tried something or they have initially declined our guidance or advice. It's building those relationships that are really the linchpin for managing substance use problems in adolescence more than anything else. So really great to be up to date on what the literature is showing us, but it all has to be taken within that context. And so the role that particularly I think school mental health and school health personnel play is just so essential in that regard. In specialty services, we see such a small fraction of the youth who really ought to be seen. So frontline folks I just can't say enough how much I admire the work that you do. So getting to the presentation. So today I'm going to give an update in teen substance use disorders, kind of a quick overview. And I have no financial interest to disclose. I will be talking about some non-FDA approved uses of medications. I'll mention that is so, and that's not a main part of the presentation, but I think it is an area that is useful to know about because it's not thought of very commonly when we think of treating adolescent substance use disorders, and I think it has more of a role than people think. Okay, so the objectives: to summarize current patterns of teen substance use and substance use disorders in the United States and a little bit locally, because this is one area, again, where I think there are a lot of misconceptions that are fed by the media. Apply best practices for screening teens for substance use disorders, and describe evidence-based interventions for teen substance use disorders. And the description of the evidence-based interventions is going to be, I'll admit, somewhat superficial, because these things are complex, but it's really good to know what's out there, and so that you can help youth and families assess whether they're getting something that sounds like it's legit. Okay, in more detail, we'll talk about they're no longer so new, but the DSM, the Diagnostic and Statistical Manual definitions of substance use disorders, which have changed over the years, and I think that the definitions and the lists of symptoms are really informative. So they're not just for the sake of diagnosis, but for the sake of kind of understanding the phenomenon of substance use disorders. I'll give an update on prevalence. We'll talk about screening and assessment, treatment. I will mention, talk a little bit about co-occurring disorders as sort of part of the treatment section, give some practical tips, and have time for Q&A. Okay, so in the DSM-5, the Psychiatric Manual of Diagnosis, we no longer use the distinction between abuse and dependence, which was kind of the cornerstone of definitions in DSM-4. And that came largely from a recognition that there certainly is no hard and fast distinction between those. It wasn't really that helpful. And also to emphasize that dependence typically implied for people a biological phenomenon, whereas abuse sort of represented more of a psychosocial phenomenon. And I think the current thinking is that you just can't tease those things out. This is, substance misuse, substance use disorders exist very much on a spectrum of severity, and they include biological, psychological, social and behavioral components, and all of them are important and to different degrees for different people and for different degrees for different substances. So we've really diminished the emphasis on this distinction, and you can see that in the list of criteria. It's very long because there are just a wide range of manifestations of substance misuse, and I put the more typically kind of biological symptoms in color just to demonstrate that they're on the list, but you definitely don't need to have you don't need to have craving, tolerance, or withdrawal to meet criteria. And on the other hand, those are certainly things that are relevant, particularly for some key substances. Of course, opioids certainly jumps out for people. So going to the epidemiologic issues. So I think right now, and I wonder if this is true. Show of hands, who in the room thinks that there is a worsening of the drug abuse epidemic amongst teens in the United States? Yeah. I would say that it's certainly a very important problem, and I have dedicated a lot of my career to helping youth with substance use problems. But if you look epidemiologically, there's a lot of evidence that actually, big picture, and there are exceptions, of course, the opioid overdose epidemic is an exception. But from a lot of perspectives, there's actually been a lot of improvement in the area of teen substance use in recent years, epidemiologically. And this we can start to see this in some of the data that we get from the NIH, where if you look, for instance, at the misuse of Vicodin over the past 10 years or so, there's actually been a really significant decline. And these are reliable statistics. That said, we have some countervailing forces where we have fentanyl on the street, and so you have a much higher risk of overdose amongst that small group of kids who is using opioids, and particularly who are thinking that they're using heroin. The risk of a very dangerous, catastrophic overdose is higher, but we're dealing with that amongst what remains a very small percentage of kids, luckily, and probably even a relatively smaller, gradually smaller percentage of kids. So the use of Vicodin, this is not use disorders, this is just misuse, a much broader category, but it has been steadily going down, and that's also true for just about every other substance except for marijuana products. That except for marijuana products, substance use has been gradually declining amongst teens in the United States. And in addition to that, if you look at the prevalence of substance use disorders, so the more serious problems from misuse, that has also been declining. And even for marijuana, while marijuana use has not been declining, and even perhaps misuse has not been declining, marijuana use disorders do appear to be declining. Across the board, we see decreases. And I think that it's very important to know, just to understand what's going on for our teens in general, and to recognize that teens are actually responding to education and, unfortunately, also understandable fear about the consequences of some of these substances, less so with marijuana. And yet we are often given a portrait of teens as completely out of control, and suggesting that we sort of have to kind of round everybody up and intervene with everybody. Whereas I think the best way to think about this is to be thinking about how are we going to get to this relatively small group of kids who really, really need us, and how are we going to intervene with them? Okay, so moving on. Another, I think, encouraging slide. So if anybody ever tells you, there's this terrible, it's terrible. Marijuana use has surpassed the use of cigarettes among teens. I would say, yeah, it's true. Marijuana use has continued at about 6% of the population. But the really good news is just how much of a decline we've seen in the use of cigarettes by teens. That's really the take-home message. Good. I think that's very reasonable, and I don't have specific data today on e-cigarettes. That said, I'm not an advocate for e-cigarettes, and I actually just reviewed a paper on recruiting youth to tobacco products using flavored tobacco products. Really big problem. I'm absolutely against it. At the same time, the health risks of e-cigarettes are markedly lower than the health risks of smoked tobacco. So again, not saying anything in favor of e-cigarettes. And I think that the nicotine dependence caused by e-cigarettes is very concerning. But I still think that there is good news out there. So as I mentioned, marijuana use continues. It has not declined. And the perception of risk with marijuana has unfortunately largely gone down. A lot of youth think that it's not a risky substance. It doesn't have harms. But that said, it hasn't led to a large-scale epidemic of marijuana use disorders. In Washington State, and I said that I would have some local data. I don't have a lot. It's hard to get local data on teens. We do have more teen marijuana use than in the United States as a whole. So that's a very real phenomenon, and I can't imagine that all of you, I imagine that all of you who work here in Washington State see how common marijuana use is and how benign it is considered to be by a lot of teenagers. And while there's good news, there also are very concerning things. I'm not trying to minimize the concerns. So what kids are smoking when they smoke marijuana is changing, and very much for the worse. So the potency, the percentage of THC in marijuana samples has gone up dramatically since about 10 years ago. So kids are getting a much higher dose of THC when they smoke marijuana. And there's some indication that hasn't been compensated for with less consumption. So kids are probably just who smoke marijuana are just plain getting more THC. And there are real harms of cannabis. And there's a lot of uncertainty about those harms, but there are some things that we can say for sure. And for almost all of these, the higher THC content of current marijuana products is probably increasing the risk very significantly. So there is a clear risk of increasing or causing psychotic symptoms and increasing the risk of psychotic disorders. Keep in mind that the overall epidemiologic rates of psychotic disorders are luckily very low. We're talking in the 1%, less than 1% range, but these are devastating disorders, and so any increase in the risk is significant. On average, studies show about a 2-fold to 2.5-fold increase in risk of developing a psychotic disorder like schizophrenia. The key point here, the key take-home, is that this is very much related to underlying vulnerability factors as well. So again, emphasizing this point that I really think that our job is to try to focus on those youth who are at higher risk. So youth who have a history of psychotic disorders in their family or are already showing psychotic symptoms or a lot of mental health symptoms, those youth are at real significant risk of worsening their symptoms and possibly even transitioning to a psychotic disorder if they are users of cannabis and especially heavy users of cannabis products. There is an association with depression, anxiety, and suicidal thoughts. There's a clear link to acute impairment in memory, judgment, and reaction time, which of course is very significant in driving. There's a clear link to motivational problems, and that's even when youth are not high. In between smoking, heavy use clearly leads to amotivation, academic failure. And this is an area that is still actively being investigated, but there's pretty good data that you can cause an irrecoverable decrease in IQ up around 6 points with early onset cannabis use disorder. So use starting before 16. And that was found in a very prominent longitudinal study. There are some studies that have found otherwise. The quality of those studies is not as good as the study that has found decreases in IQ. It's important to know about those studies, I think, because the savviest youth who are marijuana advocates and are really true believers, they're going to really come to you. If you have a dialogue with them, they're going to want to talk to you about all the evidence that shows that there aren't problems with cannabis. And so I think you have to be pretty savvy about the literature with kids who are also, in their way, savvy about this data. And there are a lot of websites that fuel that as well. There are a lot of pro-cannabis websites that kind of arm youth with data showing or conclusions showing that cannabis isn't as harmful as people might say. And then there's some risk of lung disease. And that's a real thing. It is lower than the risk of lung disease with regular tobacco smoking. So you don't want to. And I emphasize this because going back to the relationship issue. So I find that being really frank with youth about what I do and don't know and what the field does and doesn't know, and not trying to pretend that there are known risks that aren't really well documented, actually really builds the relationship. So, youth will say, well, marijuana is not as bad as cigarettes, and I'll be like, in a lot of ways, I agree with you. I'm not going to try to fight them on that because I want to engage in a dialogue, not an argument.
Quick question.
Sure.
In regards to the data that you shared about marijuana use and smoking, was the marijuana use just something that was smoked, or does this include edibles?
So I believe that it includes edibles because I think the question asks about marijuana use. Edibles are really common and popular in Washington state. I still think, my understanding is that it still represents quite a small fraction of the cannabis that's used nationwide. It seems like it's become increasingly common in recent years, but it's still a relatively small portion of cannabis products. Okay, so now going on to the issue of overdoses, because this is something that is very understandably prominent in the media and very scary. I've had my own personal experiences as a clinician with catastrophic youth overdose, so in no ways would I minimize this problem. And it is real that the rates of drug overdoses have been going up in recent years, and it is also true that that is primarily due to increased deaths from opioid overdoses, and it is most likely the case that the majority of those are actually accidental deaths, not intentional suicides. And this for sure is connected with the increasing prevalence of fentanyl on the street. So this is a situation where when I am aware of a youth who is using opioids, my level of energy around intervention just goes way up. I think that, and youth are very poorly educated about these risks. They just don't know how dangerous it is when because they don't know that they don't know that they don't know what they're getting. And it can be really, really tragic. All right, so that's why I'm gonna take a minute to just go over signs and symptoms of opioid use, because this is something where we should really try to get every kid that we run into who's using opioids and try to intervene. So the typical signs of intoxication are constricted pupils, sedation, respiratory depression, flushed, itchy skin, bradycardia. For chronic use or intravenous use, of course, exclusively, you can have track marks. And this is just a photo that illustrates those for anybody who hasn't seen them. And then it's good to know the symptoms of withdrawal, because I think in a lot of the settings that we see youth, we're more likely to see them in a state of withdrawal than in a state of intoxication. So restlessness, sweating, body aches, vomiting, diarrhea, and nausea, dilated pupils, watery eyes, tachycardia, and yawning. And this is a pretty specific syndrome to have both kind of these symptoms of adrenergic arousal along with yawning. And so if you have youth who come to you with, as I can imagine happens frequently with GI complaints, for instance, and you see evidence that they're anything that raises concern that it could be in the setting of opioid withdrawal, it's obviously a key time to intervene. And I'll speak a little bit I'll off the side about confidentiality. I would not say that I know the standards of confidentiality in school-based nursing services, so I can't speak to that. But I will say that while as adolescent psychiatrists, we certainly prize confidentiality very, very highly. When we feel that there's any imminent risk to the youth, we will break confidentiality if necessary. And we will certainly try to have the youth disclose the problem behavior themselves and guide them towards disclosure to their guardian and parent. But if they won't, and we think that they're at imminent risk, we will disclose. And physical opioid dependence, in my book, is grounds for disclosure if a youth themselves will not disclose. There's not that. There are other psychiatrists, other mental health professionals who do not see it as clearly as that. So I can't say that I am representing the whole field. I'm really giving my opinion that the risks are just too great. And I have a feeling, just to be frank also, that my opinion has been shaped by some of the experiences I've had with accidental overdoses. All right, so it's good to know the risk factors for serious problems with substances. There are many things that people would expect. They're not big shockers, but we should keep them in mind when trying to identify, again, those kids that really need intervention. I'm not going to read them all off. You guys have them in your handouts, but if you want to talk about them during the Q&A, of course, we can talk. So there are early risk factors, and then there are later risk factors. I don't think any of these would come as much of a surprise to anyone. So the summary, my take home from the epidemiologic findings is that experimentation is normative. I don't mean good, I just mean common. But consequences can be severe and far-ranging, and use disorder is luckily rare, but really does demand that we act. Overdose really is increasing, primarily due to opioids, and that we really should be looking for risk factors, early initiation, heavy use, and use of, I would add, the more acutely dangerous substances. So how do we do this? So I think that there are a number of screening tools that are reasonable screening tools, but I think that the data and practicality of the CRAFT screening tool really makes it the best one. How many people use the CRAFT already? Okay. All right. So, well, I'm glad I'm talking about the CRAFT. I'm really glad, because this is a really simple tool, but it has really great data. We think about tests in medicine as requiring a high level of technological sophistication in order to achieve sensitivity and specificity. And here we have what is essentially a one-page questionnaire that performs great. So the CRAFT is, it can be either read to the youth verbatim, or you can give it to a teen to fill out on their own. And it comes in many languages, and it's quite straightforward. You do want to do it just as the form has it laid out, so really do it verbatim in order to take advantage of its effectiveness as a screening tool. And so you begin, I'm going to ask you a few questions that I ask all my patients. Please be honest. I will keep your answers confidential. Of course, there is the form that you give directly to youth to fill out is worded slightly differently. And then you start with, during the past 12 months, on how many days did you X, Y, and Z. And then if you get, depending on the answers in the first section, you ask either just the first Part B question, so you ask everyone about whether they have ridden in a car driven by someone, including themselves, who was high or had been using alcohol or drugs. You ask that regardless, because that's obviously concerning. But you only ask the other questions if you get positives on the first section. And with just 2 yeses in the second section, you have a high likelihood that the individual has a significant problem, that they will meet criteria for a substance use disorder. The sensitivity and specificity is on the order of 80 or higher % in studies. I mean, this is a really, really simple and really, really effective screening tool. The American Academy of Pediatrics recommends using screening tools for substance use for all adolescents, and I see no specific reason that this shouldn't be used very commonly. And I also would have to say that I find youth respond really positively to this tool. And I think a lot of people I have found a lot of people kind of scared that they're going to kind of alienate a teen by asking them these questions or giving them this questionnaire. And that has just not been my experience. I've found that it has been the beginning of countless first step dialogues about use. The paper form is also, I think it's really good to keep in mind. There's evidence that it's just as good as asking the questions face to face in terms of its sensitivity and specificity. And it's a really low pressure way for youth to start to disclose to somebody who can help them what's going on. So obviously, really advocating for the use of the craft. All right, so on the other hand, I often get a lot of questions about whether to do urine testing for drugs with youth. And a lot of times, I do consultation to primary care providers, and I get this question all the time, the concern that a youth is using substances, should I do a UTOX? And, physicians, I don't know about you guys, but I know physicians, they really love tests of biological samples. So, just love them. So they're really excited. They definitely jump to urine testing while it's clear that this low-tech questionnaire is really the best first step. So there's no good data on urine testing being sensitive or specific for substance use disorders. As many of you probably know, and we can talk about more in the Q&A, most substances only show up in the urine for very short periods of time. So you don't cover a lengthy period of time when you do urine testing. It certainly isn't a rapport builder. I've never, So what you really want to do is develop an environment where the youth wants to disclose, not an environment where a youth feels like their body is being searched from within. And so there are times when urine testing is essential. If you have an acute change in mental status and you think substances are involved and you don't know which, then testing is typically considered essential, but it's still not fully reliable, and you shouldn't base all of your judgment on the results of the test. There are plenty of false positives and false negatives for the tests that we use, the first level tests that we use. For outpatient assessment, this is again from a position paper from the American Academy of Pediatrics. Voluntary and confidential urine testing may be useful, and as mentioned, there are times when breaking confidentiality is justified, but I emphasize may be useful in this case. Oftentimes there isn't a clear thing to be done with the results of urine testing other than conversation as a first step with the youth. Of course, there are exceptions. If you are concerned that a youth is using opioids and you think they have actually used very recently, and you would like to, you're pursuing confirmation of that, and you know that you're going to have to disclose that regardless of the results, that potentially could be a situation in which you would really push it. But those situations are relatively rare. I've also worked with the the King County Juvenile Drug Court, where urine testing is sort of a core part of what they do, and I will tell you, it is an absolute mess. I mean, it totally alienates the youth. They are constantly figuring out how to fake the test or get out of the test. It becomes almost the main topic of conversation, as opposed to trying to build a collaborative environment. For ongoing monitoring, testing may improve outcomes in some settings, particularly though the ones where it is done voluntarily, where you have a youth who is really wanting to stop or cut down their use, and it helps them with their own accountability. It helps as part of the relationship, not as a monitoring system. And it can actually be motivating for youth, because when youth are motivated and they're doing it voluntarily, it can be really exciting for them to show clean urine, and it can be something to celebrate. But the role for urine testing is way smaller than people often think. So if you do find a youth who screens positive or you're concerned about, then the next step ideally is a chemical dependency assessment. So a full assessment performed by a chemical dependency professional, which is a specific designation within Washington State, and ideally that uses a specialized interview, often a structured interview in the best case scenario, that covers kind of all the components of substance use disorders. The American Society of Addiction Medicine, I think, would not be called the American Society of Addiction Medicine if it was renamed today. You know, the term addiction has just become too loaded. There's just too many kind of moral connotations for people around the word addiction, but that's kind of the historical term. And these assessments can be really, really informative, and ideally they lead to a recommendation for the ideal level of care. And I will say that while this is very useful, there's much more data supporting this system in adults than there is in adolescents. So useful stuff, but definitely not, at this point, we can't say that this is the gold standard approach. And in particular, the evidence base for residential or inpatient services for substance use disorders in teens is still quite thin. People think a lot about that as an intervention, and oftentimes they think about it in this, in a longing way, especially in Washington State for state-funded youth, because it's so hard to get residential services, even if youth are motivated to do it. It's so hard to obtain. And I find a lot of times that makes people feel really disheartened, like they really can't get what the youth actually needs. But the truth is we don't know for sure that residential programs are better than evidence-based intensive outpatient programs. And so I really try to emphasize that when we can't get access to residential services, which is most of the time, that you're not necessarily getting an inferior product. We don't have to be demotivated by lack of access to this thing, which really may not be what makes the difference long term. All right, so on the other hand, what is evidence-based, or at least supported by evidence as interventions for teen substance use disorders? And here's just a partial list, and I want to emphasize the source. So the source is the Washington State Institute for Public Policy, which is a nonpartisan, government-funded research institute in Olympia, and they do a really great job of surveying the literature frequently on this topic and updating their lists of what has research support. So in the resources section, there's a link to their website. A really good thing to look at if you become interested in this area and you want to be counseling youth or families about what kind of interventions really have data backing them up. I would say in the Seattle area, the easiest service typically to access in community behavioral health is 7 Challenges, which is a group-based intervention. And promising is actually, it's better than it sounds. I think that the criteria for evidence-based by the WISSP folks is the bar is very high. I mean, you have to have really, really good data, including cost effectiveness data, to meet their highest level of designation as being evidence-based. And even promising practices have good supporting data behind them. And so 7 Challenges is a good place to start for youth who have moderate substance use disorders. Multisystemic therapy is very hard to access outside of the juvenile justice system. But it is a good thing to know about because it's so comprehensive that learning about it kind of makes you think about all the different things. I've done that a lot of times. Makes you think about all the different things that can go into supporting a youth's recovery. So key factors are that it engages the family members as collaborators, and there's one of the common elements, not in every evidence-based intervention for teen substance use, but in most, is family involvement. So family involvement to the greatest degree possible and appropriate. Of course, there are situations in which family involvement is counterproductive, but in the majority of cases, it is something really desirable. It's very strengths-based, so as opposed to pathology-based, it's really trying to foster the strengths that the youth and the family has and build on those, and by building on those, encourage activities and connectedness that displace substance use as opposed to focusing on rid of the substance use, really trying to build a fuller life. Working on barriers, and barriers are a big deal because it takes a lot of persistence often to get into and stay in services. It's really terrible that that's true, but it is the case. And I would imagine that that's a role where school health personnel could really make a big difference, is helping youth and families to continue to push through the barriers which inevitably emerge because the system is so not user-friendly. It uses cognitive behavioral therapy, but also family therapy, and involves also home visits and on-call availability. Very hard to access, but it really does demonstrate that in the ideal system, you want to have interaction with the family that works in the best ways for them. So I think that's the general principle. I know that it's not possible to go to people's homes or to be available on call, but to really think about how can we make it more likely that we can communicate with the family by making ourselves available in ways that work for them and their work schedules. I think that's a really important principle. So I'll talk a little bit, just briefly describe some of the other types of interventions, just so that people are familiar with them. So behavioral therapy usually uses reward systems, incentives for reducing use. Often these are linked to urine testing. There's preliminary evidence for some programs. I think they're especially good for youth who still are actually really motivated to quit. And the rewards are actually more symbolic than anything else. I think it's really a way to just help youth feel excited about their successes. And I think it should be seen as that rather than seen as a reward and punishment system. And we talked about CBT, cognitive behavioral therapy, which really focuses on understanding the context and triggers for use, the situations, the people, the emotions, which oftentimes it's negative emotions that trigger cravings, and then what the substance does for that person, whether it is facilitating socializing because they have a lot of social anxiety versus treating PTSD symptoms because they're overwhelmed by traumatic memories, or if it's actually that it actually has a seemingly positive role in their life, that they don't have social anxiety, but it's just become part of how they and their friends have fun. It's important to recognize that as well, because if you assume that a substance is only being used to treat a negative problem in a youth, and it's not. That youth is you're going to lose all credibility with the youth. So then also skills training around refusal and around managing emotions in ways other than using substances. And again, the effectiveness, the efficacy of cognitive behavioral therapy, which is often thought of as an individual treatment, is for sure enhanced by including a family component. Okay, so then 12-step programs. So you will note that, we've got to talk about 12-step programs. You will note that it's not on the WISP list of evidence-based interventions. That does not mean that it has been found to be ineffective. It is certainly the most common intervention done for youth and adults with substance use problems. Far and away the most common thing that occurs. I think people probably know a little bit about 12-step, and we can talk more about it if people want to. It is important to recognize that there has been no randomized clinical trial on 12-step programs in adolescents, and the data supporting it as an effective treatment, it's actually pretty thin. So that said, without question, there are youth who get involved in 12-step programs, and it is great for them, and it works, and it's wonderful. When it works, when it's the right fit, it's wonderful because it's so accessible, it's so available. The barriers to entry are actually so low. There's meetings all the time, and good meetings are incredibly supportive. If you haven't been to an AA meeting in your lifetime, I absolutely encourage you to go to one. Some are intentionally open to observers. You learn so much about the organization just from one meeting and about the sense of community which it can provide. And it's a really big part of so many people's lives. So I really encourage you to check it out. It can be incredibly moving. And I'm not at all an opponent to 12-step. I have seen youth get a lot out of it. That said, it's just not a good match for everybody by any stretch. And I think that's partly why it doesn't necessarily perform that well in studies. So amongst the youth who stay with it, they do great. But that's a relatively small percentage of folks who start off and have a first experience. And just mentioning harm reduction, it's not a specific intervention, it's really a philosophy. We can talk more about that as well, that I think people should be aware of if they're not aware of it. Just actually show of hands, who feels like they're sort of familiar to a significant degree with the concept of harm reduction in substance use? Well, I'm glad I'm mentioning it. So this represents really a sea change in thinking about substance use. The idea being that we're really, although we would like people to become abstinent when they're using harmful substances, that is not our goal in the interaction. Our goal in the interaction is helping people reduce the consequences of use rather than demanding or promoting abstinence, because for folks who are do not themselves have the goal of abstinence, it can be very alienating for you to be pushing that goal. But you can do a lot, because for most people, they do want to reduce the consequences of their use, even if they want to keep using. And in the adult world, there are some really famous and wonderful demonstration projects here in Seattle on the harm reduction approach. There is what's called wet housing, which are supported housing for adults with severe alcohol use disorder, very severe alcohol use disorder, and the housing, unlike most supported housing, does not require that the person says they're not going to drink. And so they're allowed to drink on site in their public housing. And they find that there are really significant decreases in use. So even if you're not aiming for decreased use, if you provide people with a place to live, their use goes down, decrease in the health consequences of alcohol use, and decrease in crime related to the use. So this is one of the really demonstrates that treatment of substance use disorders often has to do with improving the overall life of the individual rather than just aiming like trying to put a scalpel and cut out the substance use itself. And that when people's lives are better, they will naturally, typically use less and use more safely. And then there is motivational interviewing, which there's a form of that that's on the WISP list, but it's really also a general philosophy that really focuses, it's associated with harm reduction, but really focuses on helping people to find their own inner motivation for change rather than trying to persuade or force people to change. And if you're interested in this area, I really encourage you to learn more about motivational interviewing, go to a training. I think that it can be quite profound, and it also is a great remedy for burnout, because motivational interviewing recognizes that you can't make people change. And so you sort of stop banging your head against the wall with people who you see doing stuff that you're really concerned about and you really want them to change. You know they need to change, but they're not changing. And that can be so exhausting for both of you. And so if you can feel confident about kind of approaching it from a different angle, I think the stress level, your own stress level and the youth stress level goes down. And again, the chances for the opportunity for collaboration really goes up. So highly recommend learning more about motivational interviewing. I'm going to just rocket through these final slides. So there are medication treatments that are sometimes used for substance use disorders themselves when they're serious. None of them are FDA approved for this use, but they potentially have a role. And I mention this because if somebody really is trying to quit one of these substances and they're unsuccessful, I think this should be considered. And it often isn't considered because people don't think that it's possible that a medication can help with substance use. But there are substances for which medications that can be helpful. And in particular, people are very fearful of opiate replacement therapies. And a lot of people, even in the addictions world, think that they should never be used, they could never be used. It would be terrible. How can you ever use it for an adolescent? But there is data that supports the use of buprenorphine, Suboxone, and methadone in adolescents. And because the consequences of those use disorders can be so severe, I think these should be on the table. We can talk more about that. So as you can imagine, co-occurring mental health disorders are the rule, not the exception. So ideally, you're helping youth to find treatment for both mental health and substance use disorders simultaneously. Those are the conditions that are commonly co-occurring. People can be fearful of using medications for psychiatric disorders in the setting of substance use, but there are many situations in which it is a reasonable thing to do, and there are studies supporting it. So the overall summary: the sky is not falling, in my opinion. Not trying to minimize the problem, but there is a core group of very impaired teens that really needs to be identified and referred again and referred again and referred again. And we need to talk to them in motivational ways to get them to accept referrals. And we need to really focus a lot of energy on those teens. Marijuana I would say, does have greater risks than many people recognize, and there is a very real and scary overdose epidemic, which again leads me to want to focus on the youth who are at highest risk. I highly recommend screening using the CRAFT. The best supported interventions use well-defined, structured approaches with family involvement. And then substance use is generally not a contraindication to appropriate psychiatric medications for co-occurring conditions, and consider medication-assisted treatment in youth who are actually physically dependent on opioids, given the level of risk involved. And here's some resources that will help, hopefully, to guide you towards services for youth. And that's it. Thank you very much.
In regards to harm reduction, is there currently in the Seattle or other state areas places where people can take their drugs to check for fentanyl?
I actually do not know the answer to that. But if somebody else does, I would like to know.
Yeah, so in the U District here in Seattle, at the Needle Exchange next to Roots in the alley, I don't know the address, it's like 42nd. There's the People's Harm Reduction Alliance, and they can take their bag of whatever drugs in there, and they can tell them what's in it.
So I'm going to repeat the question for those who are not present. So the question was, are there places in Seattle where somebody who is using can bring their drugs to be checked for fentanyl? And I think the answer, we heard the answer that in the U District at the Harm Reduction Alliance, which is something that I did not know about and I'm thrilled to hear about.
Here.
So under your craft assessment, I was just thinking about an interaction I had with a teenager that they were a high-performing student and they were using Adderall to stay awake longer as well as marijuana to stay focused. And so when I was looking through those questions, I could imagine them saying no to those things because they weren't using it to get high. And how do you approach that when is it just building a relationship? Like how do we...
Yeah, so of course, the question is, how do you approach misuse of Adderall and other ADHD stimulants for performance rather than getting high, because that would not be picked up on the craft screening tool. And that is, I think, through the same concepts as illustrated in the craft screening tool, but done face-to-face and focused on the substance that they are misusing. So the craft screening tool, great tool, but definitely doesn't pick up everything. And for sure, the relationship issue is key. And I think the motivational interviewing approach is very helpful here. Part of one of the main principles in motivational interviewing is what's called developing discrepancy, which is helping somebody to identify the gap between their values and goals and their current behavior. And even with Adderall misuse, there often are conversations to be had about that, because in my experience, most teens who seriously misuse Adderall actually have some adverse effects from it, but they need a collaborative environment in which to disclose those effects. Insomnia, anxiety, in some cases paranoia, fear of consequence, fear of getting caught. For high-performing students, fear of getting caught and not having negative consequences for their college admissions amongst the high performers. So there is a conversation to be had around those things.
Kratom is kind of making more headlines, I guess, or you see it being sold at the smoke shops, and it's currently still unregulated. Are you aware of any science behind studies of using it as an alternative to opioid, or using it as a treatment to opioid addiction? What are you aware of the risks of using kratom, just recreationally? And then are you seeing an uptick in youth use in your practice?
So the question is, have there been, regarding kratom, which is sold in smoke shops, and are there studies on using it as a replacement treatment for opioid dependence, opioid use disorders, and are you seeing an uptick of use by teens in your practice? So regarding question one, there have been some exploratory studies. They don't look very reassuring to me. I think that it's based on the idea that because something is purportedly more natural, that it's somehow a safer bet. But kratom is really complicated substance that has opioid qualities and also stimulant qualities. And so I think people in the substance use treatment world are very skeptical of its use for that. And there certainly aren't good studies that I'm aware of. As far as an uptick in use, amongst teens, I have not seen much kratom use. Amongst transitional age youth, I have started to see that. What people get when they think they're getting kratom is also really questionable. So you hear about such different reactions to what is purportedly the same thing that it really leads you to wonder whether people are getting a wide range of different substances packaged as kratom.
I have a question. Can you touch base just really briefly about THC and alcohol receptor sites in the brain, and if they are the same receptor sites, and do they use the same neurotransmitters?
So the question was, can I touch briefly on THC and alcohol receptor sites in the brain, and are they the same receptor sites, and do they involve the same neurotransmitters? So I will not claim to be an expert on the neurochemistry of THC or alcoholism, but it certainly isn't identical. There are specific receptors for THC, which are not the same receptors and do not necessarily work exclusively in the same system as alcohol does, the GABA system. THC has effects in multiple systems, and that's probably why it is the more harmful component in cannabis products. So cannabis products have the active components are typically THC and then cannabidiol, and there are receptors for both. And the cannabidiol appears to be a much less harmful of the two, but both of them have effects that do not overlap entirely with alcohol.
So in one of your earlier slides, it mentioned with marijuana use, anxiety, depression, but we're seeing that a lot of general practitioners are seeing kids with anxiety and prescribing
Yes.
marijuana use. So where do we go with that?
Yeah. So the question is, I think, or one way to phrase the question is there a role for prescribing cannabis products for depression and anxiety in youth? And I believe that at this point there is no legitimate role for prescribing cannabis products for those conditions. There's just too much uncertainty both about what people are actually getting when they purchase cannabis products, and then what the longer term effects are. So there's no doubt that for a lot of people, using marijuana or another cannabis product will acutely decrease anxiety and will acutely improve mood. But there's also data that ongoing use has a high risk of worsening anxiety and worsening mood. There's going to be a next generation of research into cannabidiol, the other component in besides THC, the other active component in cannabis products. And I think out of that may come some therapeutic agents that have a real legitimate role, but it's still very preliminary. And the things that are called cannabidiol-only products in the marijuana industry are not cannabidiol-only products, and there's a lot of uncertainty about what actually is in it, and there is almost always THC in it, and actually by law, currently, you have to have some THC in a marijuana product to sell it under the marijuana laws. So it's a really complicated situation. Yeah.
What does NAC stand for in the cannabis off-use medication?
So the question is, what does NAC stand for in the slide on the treatment of cannabis use disorder or marijuana use disorder? So that's N-acetylcysteine, an over-the-counter agent which most people who are familiar with it know as a treatment for acute Tylenol overdose. And it has been found to have a role in decreasing cravings. The best research in teens is in cannabis, but it may be that it has a more general effect on cravings for other substances as well. It's a very, very safe thing to do. So for a youth who is motivated and really wants support, that's probably, I have a very low threshold for encouraging them to use NAC.
I think we have time for one more, maybe two. Let's go ahead. We can start.
So my question is, since many of us are school nurses and we might interact with a student that we find out is using, and using the mindset of reducing harm, as you were talking about, like I compare it to safe sex, right? I mean, we're all kind of doing that now. We're not necessarily saying, no, you can't have sex, but these are the safe ways. But the consequence of those isn't death. So now I'm sitting here as a nurse and I'm telling my student, well, if you're going to do it, here's the safe ways. So can you kind of tell me some real concrete things that I could advise them that would make it more safe? Like I would say, well, don't get in a car, but then I feel like, am I encouraging them to go out in a field or at a friend's house and then nobody knows and they're, you know what I mean? I just feel like there's this spiral that could have a really horrible consequence, you know?
So it's the question is, what are some practical ways to discuss and safe ways to discuss, to use a harm reduction approach with youth who have scary substance use? And I think your car example is actually a really good one of exactly the kind of thing that I would do. So I think there's no doubt that getting into a car with people who are intoxicated is one of the most dangerous things that you can do. And unfortunately, I have personal experience with that as well. So yeah, I have to say, I think saying, if you're going to use, I think you're so much better off using anywhere but in a car, or using anywhere that you won't be driving with somebody who's intoxicated. I think that's a totally legitimate approach. I don't think that you're condoning use by doing that. I think that you're showing that you really care about their well-being. You don't care about their use specifically, you care about their safety. So I think that's actually a perfectly fine thing to do.
Do you ever give, like, I have a son who just started college, and they do a lot of education about leaving kids in a corner that's, drunk or high or whatever. Do you ever try to talk to your teens about that, about how to monitor somebody or what they should do?
I do. I don't have a protocol for doing that, and I certainly do it more when I'm talking to teens who have the kind of use that really does require monitoring. I do end up talking about it a lot, actually, with binge drinking, particularly with younger teens who are just starting to experiment and have no idea how dangerous binge drinking can be. And so I talk a lot. I try to engage them in a conversation about it and what kind of signs to look for, and also education around the delayed effect of drinking, that they're not going to know right away how hard the amount of alcohol they've just drank is going to hit them. And their friends won't know, and that they should be watching what their friends are drinking with that in mind.
So I'm afraid we've run out of time because we're heading into our lunch break, but I want to just give everyone
Thank you all.